Welcome everyone to our webinar on psychiatric medications for kids and teens, a Q&A with Dr. Hanna. My name is Brian O'Malley. I'm with MedPsych Behavioral Health, and with us is Dr. Mohab Hanna, who is founder of MedPsych Behavioral Health and a board-certified child and adolescent psychiatrist. And during this time, we will be taking your questions. Dr. Hanna will be taking any and all of your questions live. We also have some questions that were submitted in advance, but feel free to ask us whatever's on your mind about this topic. Just by quick background, MedPsych Behavioral Health offers psychiatry, psychotherapy, autism, and ADHD testing and coaching services for children, adolescents, and adult populations. We have offices in Ramsey, Old Tappan, Montclair, and a new office opening in a few weeks in Ridgewood, Glen Rock area. And we also serve patients and clients in a virtual setting as well, so can serve New Jersey and New York for that. So I wanted to start by mentioning that our Q&A in your Zoom is where you can raise your questions. Those questions will only be seen by us here, so it's kind of anonymous to everybody else. So please feel free to ask questions throughout the webinar. And I wanted to actually start so you can get familiar with it with I guess a couple quick questions. Yeah, the first one is maybe if you'd like, just mention where you are coming from, like a town or a town that you're in, so we can kind of see where you're at. Actually, somebody welcome is actually coming from the UK, so welcome as well. Also, also had another question for you too, which is we're wanting to know your feedback around these webinar times. So from your perspective, would you prefer, and you can just write this in, would you prefer a noon webinar on a weekday, like a 5 p.m., or more of an evening time, like a 7:30? So I'll give folks a moment to write in your thoughts, either your town or preference on timing. And I hope you all can find the Q&A okay. Okay, we're seeing someone from New York, welcome. A preference for 1 p.m. Have some questions coming in as well. So thanks. We'll feel free to answer those as we go. But thank you. Thanks for your responses. This is great. All right, so we'll get started, and feel free to respond to those, but we'll go ahead and get started with a question that's come in. Dr. Hanna, what is the earliest age for considering psychiatric medications for kids?
Thank you, Brian. As Brian said, I am a child psychiatrist by training and clinical experience. I've been in full-time psychiatric practice, mostly seeing kids and teens since 2002. So I think I'll be finishing 22 years of being in full-time practice at the end of June. So I finished my training in Baltimore at Johns Hopkins in 2002. So I appreciate that question for many reasons, because I get asked this question quite often, actually, when I do some evaluations where parents appropriately will ask, is it even safe to prescribe at this age? And the answer, of course, like most questions, it depends. And it also depends on what we mean by safe. And so, or even appropriate. The way to think about this, let's kind of pretend we're not even talking about just psychiatric medications. Really, we're talking about how do we approach any kind of treatment? And we kind of must have some rules to guide us. And the way to think about this is, does the benefit of the medication outweigh its risks? What's the risk of not treating? What happens if we don't use the medicine? And have other alternatives been looked at? So there is a process to being able to answer this question. And the process usually involves understanding what is the problem from a diagnostic perspective. Because in order to think about safety of medications in kids, we have to be very clear on what it is we're treating. And does this really even warrant a medicine? And I kind of think of it backwards, kind of going back into my 3 points. What have we tried to do? What has been attempted as an alternative to psychiatric medications? And then number 2 is, if I don't use this medicine, what are the consequences? And so that guides. So for example, let's say you're seeing a 6-year-old with anxiety. Well, a lot of it will depend on the level of the severity of the anxiety. If the anxiety is mild or moderate, I'm not so sure the benefit outweighs the risk of the medications, because it is appropriate to be cautious, because children and younger children, for example, if treating anxiety, those medications are higher risk, right? Younger kids have a higher risk of getting activated or getting disinhibited or having negative reactions from psychiatric medications like Prozac and Zoloft than perhaps older kids. And so I would have concerns about safety. And so the decision of what is appropriate and how young and how old, a lot of it really depends on the specific situation, Brian, that sometimes 14 is too young. Sometimes 18 is too young. And then sometimes 6 is not too young. And a lot of it really depends on the circumstance. If I am seeing someone who is just someone, let's say, who has severe developmental disabilities, who is physically violent and is hurting themselves and hurting other people, I think about that very differently than someone who has mild anxiety or mild ADHD in terms of even the way my perception of safety. And so we're always weighing things, benefit versus risk. And what's my risk of not treating? Those are the guiding principles. And what else have we tried? And with younger kids, we should be more cautious. They do have a higher risk of side effects from all psychiatric medications across the board. And they do need lower dosing if they're even going to go on medicine. So the threshold for us being willing to prescribe does change based on age. The younger the child is, the more cautious we get. So it's not a specific number. It's always based on the situation and looking at the entire big picture after a thorough evaluation. And there's no way around thinking about medications without a thorough evaluation. So it's not uncommon that the first medicine children go on is an ADHD medicine. Most times, and that's fine, done by primary care or neurology. The challenge is if there's other things going on that would make those medications not a good idea. So then sometimes for those younger children, there's other things going on that should make us slow down and pause before we prescribe.
Okay, another question that came in, Dr. Hanna, is what side effects of medications for kids are you most worried about?
Yeah. Again, another really good question, because sometimes what I'm worried about is not what my patients are worried about. What I get concerned about, it obviously depends on the kind of medicine. We, at least as a practice, as a group, we rarely prescribe antipsychotic medications, because those medications are heavy duty, and we rarely prescribe those. So we could just say off the bat, because there's a whole lot of side effects I worry about with those medications, primarily movement disorders like tremors, restlessness, something called tardive dyskinesia, which can be a long-term side effects, weight gain, need for blood work. Those are the kinds of things I get concerned about. Some of the medical side effects, but we rarely prescribe those. Same thing with benzodiazepines like Xanax, Ativan, Valium, Ativan, right? That class of medications, I have tremendous amount of concerns about prescribing those, because those are habit forming. A lot of times people will ask me to prescribe those for their kids or teenagers who are having bad anxiety, and I'm generally very resistant, because of how much they can become addicting, and that they can actually cause depression and make kids really sleepy. And so those are the side effects I'm concerned about. The two most common classes of medications that are typically used in kids and teens are the SSRIs. Just for those of you who don't know, those are the selective serotonin reuptake inhibitors. That's the most common type of medicine used for anxiety and depression in kids and teens. That's first line. The American Academy of Child and Adolescent Psychiatry and their practice parameters, the American Academy of Pediatrics, those are first line medications, right? It doesn't mean that's first line treatment, by the way, just to be clear. Cognitive behavioral therapy for mild to moderate is the recommendation that we do first before we ever prescribe psychiatric medications for those types of things, assuming that the child or the adolescent is a good candidate for therapy and is actually able to utilize therapy. So that class of medications, under those medications, we would have fluoxetine, better known as Prozac, sertraline, better known as Zoloft, paroxetine, better known as Paxil, fluvoxamine, better known as Luvox, citalopram, better known as Celexa, and escitalopram, better known as Lexapro. Those are the most common medications used. The side effects I get concerned about are not the occasional stomachache or headache, or even nausea, or the physical side effects. Those tend to go away. I do get concerns that some kids, if they get sleepy from a medication, that's a problem. If someone is feeling sedated and doesn't go away, or if a medication is disrupting someone's sleep and it doesn't go away after the 4, 5, 6 days. Those are problematic, but that's not what my biggest concern is. My biggest concern is that we know that a certain percentage of children will have paradoxical reactions to these medications. It will do the exact opposite from what we want. I'm treating them for anxiety. It can make their anxiety worse. I'm treating them for being sad or depressed, or because they're very irritable and they have a depression. It can do the opposite. So connected to that is every single one of those medications that I listed, every single antidepressant in every single class has a black box warning that's designated by the FDA on the labeling. A black box warning is a serious level of warning that can go on any type of medicine, not just psychiatric medication, but the increased risk for suicidal thoughts. So I would say that's my biggest concern. My biggest concern is that if these medications are prescribed too aggressively and not with close monitoring, it can make things seriously worse. It can take someone who has a mild or a moderate depression and cause suicide thoughts if not done correctly. That's why our approach that we preach, not just me, to our entire providers here, our psychiatry providers at MedPsych, is very low, very slow. We use a microdosing strategy that is very, very deliberate to mitigate against the risk of running into that. So this is preventable if the medications are prescribed correctly, if they're prescribed with a very, very conservative, cautious approach. So we are not in a rush when we are prescribing, because I err on the side of caution to prevent that risk, because that's my biggest concern. So that's one concern. The other concern is in a certain group of kids, the SSRIs, that class of medications, can, in some kids, unmask mania if someone has an underlying bipolar disorder. It's extremely rare, but it is a concern that I have, that I discuss if there's a family history of bipolar. It's something I want to make sure all my patients are aware of, and for all parents to be aware of those risks. For somebody having their moods go up too high, because if a mood that goes up, it actually causes what we call rapid cycling, where we have high highs and low lows, and you usually see a tremendous amount of irritability and agitation and moodiness associated from those medications. So my biggest concern about that class of medications are the psychiatric side effects. I'm not necessarily concerned about when patients ask me do I think those medications are addicting. SSRIs are not addicting. I actually run into a bigger issue of people forgetting to take their medications. No one is craving the medication, where they have intense cravings to go on a medication. They're not getting a high from it, because that's a question I get frequently. Do I have concerns about addiction? That's typically not a concern we have with this class of medication. So the biggest concerns are the psychiatric side effects of the paradoxical reactions, the suicidal side effects, and the high highs of mania and bipolar. The other really common class of medications that we use are the ADHD medications. And as I mentioned earlier, those are typically prescribed frequently by primary care, not necessarily child psychiatry, but we are sometimes the ones who are starting them. So the risks and side effects, the concerns I have there are actually much more than the SSRIs. Some of the common ones that I have concerns about are these medications can suppress appetite and can impact the rate of growth of kids. So that requires me needing to monitor height and weight over time. So that's a side effect that I have concerns about. I have concerns about those medications, whether kids, teens, and actually sometimes more prominently in adults, because they do increase your blood pressure and your heart rate. So we need to monitor blood pressure and heart rate. So that's a concern we have that we need to monitor closely. And as a matter of fact, I will gauge safety and my ability to dose the medication based on the blood pressure and pulse. If you're one of my patients listening to this, I've asked some of you to get electrocardiograms at times, EKGs. If you have a family history of cardiac arrhythmias or anything unusual, we will sometimes ask you to get an EKG. If you have a son or daughter who's adopted, and I don't know the family history, sometimes we ask you to get an EKG. If your child, son or daughter has an underlying cardiac issue, sometimes we'll ask you to get an electrocardiogram to make sure safety-wise. So those are some of the biggies. Other ones that I have concerns about is that those medications, the stimulant medications, the ADHD medications, can cause a lot of mood side effects. They can make kids more emotional, more sensitive, more irritable, more sad, more down, more nervous, sometimes even flat emotionally, or feel less social. I just listed a whole lot of side effects. You're probably thinking, okay, why should we ever go on these types of medications? And it goes back to the principle, does the benefit outweigh the risk? And I'm not okay with any of those side effects. This is why we monitor. Because if we're going to prescribe a medication like this, we got to have clear benefit and clear tolerability. I've said this to so many people over the years. I'm not okay if your son or daughter feels like they have no emotions on this medicine. That's not okay. Even though the medication might be working amazing and they're getting straight A's and the school thinks this is great, I'm still not okay with it. Because benefit has to outweigh risk. We got to have clear benefit, clear tolerability. The ADHD medications, the stimulants, in some kids with underlying tic disorders, they can unmask tics, motor tics, vocal tics like Tourette's. Another side effect, that I have concerns about. In kids who have obsessive compulsive tendencies like OCD, it can make those worse. My big thing here that I preach is we need to monitor. We need to be aware of the side effects. We need to make sure that it makes sense to use the medicine to even start, that the benefit outweighs the risk, that the risk of not treating is not okay, not good, that it warrants us doing a trial with this medicine, and we monitor like hawks. We micro-monitor because we have to. Because these medications do have a whole lot of negatives. They can work amazing and great and be life-altering for some children when they're indicated and when they're appropriate, when there's clear tolerability.
So here's a question that came in live that's kind of a follow-up to what you were describing, maybe almost like a case study. By the way, I'll just mention again, for those on, use the Q&A, ask us questions, only we see it, and we're happy to work through them. So the question is, what's the guidance on dosing stimulants such as Adderall, which have a very wide dosage span? Surely start low, but how to decide when to increase the dose?
Yeah, great question. I start at the lowest dose regardless. So if your son is 6 or your son is 15, I'm starting at the lowest dose. And sometimes even whether it's Adderall or Ritalin or Focalin, I'm starting at sometimes 2.5 milligrams. Actually, with some younger kids, sometimes I'll even start at 1.25. We'll use liquid. So we always start at lowest dose. And we basically do what we call a test dose. I need to make sure that there's nothing unusual. There's nothing unique about this patient's biochemistry or how they metabolize medications. So I basically say safety, tolerability first. Make sure there's nothing unusual. Assuming there's nothing unusual, then the next step is is there any kind of benefit? So based on the level of benefit we see on a list, guides us in terms of next steps. So we're using safety, tolerability, and by the way, safety also includes blood pressure and pulse. So there are times where I will do the lowest dose, but that lowest dose, even though everything looks good on the surface, it's raising the blood pressure and pulse too much. I can't go up. I cannot optimize that medicine, and I have to switch and start over. Assuming that's not the case, that there's no issues with blood pressure and pulse, and there's tolerability, then we will increase based on how many hours of the day. Because one of the things people don't realize is that the higher the dose, the longer the duration of action. Whether it's Adderall or any of the other stimulants, they're short acting and long acting. So a lot of it will depend on what our goals are. My philosophy a lot of times is good enough. I'm not looking for perfection. We're not looking to have somebody be a robot. We're looking for that there's a compelling enough of a benefit in terms of treating the core symptoms that we're concerned about, whether it's the hyperactivity, impulsivity, or the focus and attention distractibility, working memory piece, and dosing according to that. Safety guides me. I'm always aware of my blood pressure and pulse, sleeping and eating, the emotional side effects. So that's what usually holds us back, is the tolerability side. I don't aim for a number. A lot of times people will ask me, what's my target dose? I do not have a target dose. I have had sometimes college students take lower dosing than 6-year-olds. So I do not target a number. I go based on what is happening in real life, the level of benefit. Those are the variables, benefit and tolerability, right? And that guides us in terms of being able to make that decision.
There's a question that came in, following up on that. What do you do when kids go to college and they are taking ADHD medications that are considered narcotics?
Yeah. I have a mini lecture I give. You get a locked box. You don't tell your roommate or anyone else you have ADHD, and not because you're embarrassed about your ADHD, not because you're ashamed of it, or not because you're trying to hide a secret, but what I have found over the years, that when college students share with their friends or their roommate that they have ADHD, there's an assumption they have medications in the room, and inevitably they will get asked for it. It's one of those things that it's happened to so many of my patients that I kind of have the same lecture. You don't tell anybody, you lock it up, you don't share it with anybody. You certainly don't ever take money for it. That's a federal crime of drug dealing. And so we kind of have certain parameters. I find, again, that, as I mentioned before about kids forgetting to take their medications, that what happens pretty frequently is they forget to take their medications, or they don't want to take their medications. The nice thing is I know exactly when the prescription goes in, because there's laws in place that we can't write refills, and there's rules in place about how often we put scripts in. So we know if someone's using more than they should. So we really control on the prescription side. We know the dates it goes in. It can't be filled too early. Nothing's foolproof. Those conversations need to be had. Parents need to kind of reinforce it. But it's a concern that I've always had about kids leaving their medications out, someone taking it, someone stealing it, someone taking a medicine that they've never been on at a dose that's higher than it should, where they start having cardiac side effects, or they have a horrible reaction to it, because they've never been on it before. But it is a concern. We continue to see our patients. We monitor them. We see them during breaks frequently. And at times we do remote appointments based depending on where the student is geographically, that we're able to do that to continue to monitor. But I've seen a very large number of college students over the years who are on ADHD medications, and we continue to provide them care.
Here's a question that came in. What is the brain damage and brain recovery from stimulant use in teens?
Not sure what someone means by brain damage, so that's hard to know. But as I mentioned, those medications do have side effects. So stimulants are speed. They're stimulants. So they can be habit forming. So too much stimulant is certainly a problem, and there is a withdrawal that can happen from too much stimulant. As I mentioned, the stimulants can have very serious negative side effects on altering mood. They can cause a tremendous amount of irritability. They can cause a tremendous amount of anxiety. So I'm not sure if the word damage, how it's being used, but as I indicated, they do have potential serious side effects in terms of um, anxiety, depression, agitation, irritability. My concern a lot of times if someone's using too much stimulant is cardiac. You can get tachycardia, you can get an increased heart rate and cause an arrhythmia. So they are that serious. They can raise your blood pressure too much. So that's the damage I am concerned about, is the dose-related negative side effects are real. This is why we monitor so hard and so close. And if you do stop, you can go into withdrawal. One of the things I'll see, even at sometimes not a high dose, if someone has been taking a stimulant for months in a row and you stop the medicine abruptly, you can get withdrawal. You will get an exaggeration of ADHD symptoms. You will be more hyper. You will be more anxious. You will be more moody. You will be more unfocused and more distracted than your baseline as a withdrawal. So there is a withdrawal from stimulants that sometimes is underappreciated. And then it can take sometimes up to 5-7 days to correct. I've seen some patients where it might take up to 2 weeks. That's why we don't stop them abruptly. That's why we wean off. So there's definitely a tolerance that develops to them, and there is a withdrawal. And this is why they're controlled substances, because they are potentially habit forming. There are some kids who abuse stimulants, and it is a problem. I've had kids over the years who try to snort it, or try to get high from it. So it is definitely, they are problematic and they do require close monitoring.
Here's a great question that's come in, kind of a follow-up to some of these other questions. Wouldn't it be more beneficial to manage ADHD without medication due to all these side effects?
So going back to my original point about benefit versus risk, if the potential benefit of medicine that way it's risk, the answer is yes. So that's something we need to be clear about. Just because someone has ADHD does not mean they should go on psychiatric medications. Having a diagnosis of any kind psychiatrically is not necessarily an indication to use a medicine. I'm saying this as someone who prescribes. Like, this is my specialty. I specialize, I'm an expert in psychopharmacology for kids and teens. And I strongly believe that having a diagnosis of ADHD does not automatically warrant a treatment with medicine. Going back to my original principles, we need guiding principles of how we think about these things. What is my risk of not treating? Have we tried all those other things? What have we tried? And have we tried legitimate things? Have we done sometimes, whether it's a middle school, high school kid, have we tried some behavioral training? Have we tried some executive function training? Our practice does ADHD coaching to help kids to be organized, to come up with strategies to manage their time, to structure their afternoons. It's a challenge. It is certainly a challenge. It is certainly a challenge for sometimes their abilities to follow through with it. The risk of not treating at times is very significant, where the benefit of the medicine actually does outweigh its risk. When I'm seeing, for example, a child who has been kicked out of 3 preschools, because those are the kids we sometimes see, or in kindergarten, where they're just physically so impulsive, there's a lot of negative consequences to that. Again, that doesn't necessarily mean go on meds, by the way. I'm not saying that's even an automatic indication. I don't have an automatic indication for anyone to ever go on ADHD medications. There are plenty of people who have ADHD who are not on medications and they're doing fine, because there's one variable that I have not mentioned so far. How much does this issue interfere with function? How problematic is this? Someone could have ADHD, and if they're functioning fine, there is no indication for ADHD medication trial. One of the interesting things is that, and I appreciate this more sometimes from some of my older patients, sometimes actually my adult patients who have had ADHD. And one of the reasons they choose to treat their ADHD with medications is actually the secondary anxiety and depression. because the ADHD is interfering with their function. And it's, as some of them have said to me, it's ruining my life. They're actually struggling in a very significant way from a functional perspective, either academically, vocationally, or relationally, or in just being able to manage life with pretty significant anxiety and depression, that the medication trial is worth it. So sometimes ADHD, people think of it, oh, as a kid who can't sit still. If that's truly what it is, if it's just someone who can't sit still, that is not an indication to use a medicine. But there's much more to ADHD than that, where there is a legitimate reason for us to consider a medicine. By me telling you all these negative side effects, I'm not trying to scare you, and I'm not trying to say not to do a medication trial. I think what matters to me huge is benefit versus risk of not treating. Have we tried other alternatives? How much is the diagnosis interfering with function? And here's the thing. How is this being prescribed? Is it being prescribed in a cautious, judicious manner with close monitoring? Or are we just saying, all right, why don't you go try this and see what happens? Without really understanding the risks and negative side effects and the level of monitoring that is indicated? That's a great question, and I really appreciate that.
We've had a few questions that are around just general ADHD. It kind of follows up on these discussions. I'll just ask one here. How do we know what is developmentally normal and or a weak executive functioning skill versus ADHD diagnosis?
Yeah, this is the benefit of doing a diagnostic evaluation. This is why it's not a 15, 20 minute. When we're seeing kids, we're doing usually, at least 90 minutes, because I want to know the whole history. In order for me to decipher what's developmental, just immaturity, versus real ADHD, is I need a full developmental history, because there are some kids who are just immature. I actually think that one of the most common reasons some kids get misdiagnosed with ADHD is immaturity. Kids with birthdays, late birthdays, your sometimes your November birthdays, or is it, I guess, late summer birthdays, your August, September birthdays, where kids are actually significantly younger than their peers. And what happens is they're being asked to navigate the world of kids who are like 8 to 9 months older than them. So that means teachers and parents, everyone has an expectation that they're going to act a certain way, and they're just being their age. They don't have ADHD. So their frontal lobes are actually developing appropriately, and it's just a mismatch of the class they're in. Or sometimes they're just delayed. Some children, just their frontal lobes are developing 3, 4, 5, 6, 9 months later than everyone else. And some of those kids, you will have seen developmental delays all along. You could look back and go, they're just running behind. It is not ADHD. A lot of those kids I see are getting diagnosed with ADHD and are being put on medications, and they should not be. So it's really getting a good developmental history and understanding the big picture of ADHD usually is present in all different locations, all different settings. And so kind of to differentiate this whole notion of a weak executive function system, is it just that versus ADHD, is looking at the big picture, right? Is this the kind of thing where somebody just has a weak executive function system, or there's much more pervasive other symptoms present? So saying someone is forgetful, like let's just, as one of the things that comes up, their working memory, if that's really the only symptom, then that should be focused on behaviorally, right? One symptom is not a diagnosis. This is why you go through the effort of really trying to understand holistically and globally what is going on. And sometimes kids just have learning issues. It's a learning disability. It's not ADHD, because they're struggling with their focus and attention with reading or with doing math, right? You look at the whole entire big picture. That's why you go through the process, to be able to figure that out. Great question.
Okay, here's one. I've been told that with diagnoses of ASD, autism, ADHD, and bipolar, the combination of a mood stabilizer and stimulant may not be effective and may actually be counterproductive. What is recommended?
That's a hard question to answer without knowing the specific situation. But if we speak in generalities, I would say that having ADHD and bipolar, just to kind of do a little bit of a just understanding diagnostically, especially because for seeing children and teens. So there's a subset of kids who have severe ADHD who end up being our bipolar patients in their older teens and 20s. And it's not uncommon that those kids actually can be challenging in treating their ADHD, because what we perceive as ADHD is actually mood. And it is really hard. I got to tell you, as a clinician, it's one of the toughest things for kids who have severe ADHD to sometimes differentiate what is ADHD and what's mood. Is this early mania? Is this bipolar? Is it not? Can be hard to figure out diagnostically, because early onset bipolar in kids, especially prepubertal, is so extremely rare. I have seen it. I've treated thousands of kids. So you treat thousands of kids, you end up seeing everything over the years, but it's still really, really, really rare. And so that's just one point right there. In terms of the mood stabilizers are not indicated for ADHD. The only reason I would ever do a mood stabilizer is if there really was a legitimate, clear bipolar indication to do that. And I wouldn't expect to treat the ADHD symptoms. So that's a tough combination, and it's not uncommon if someone has bipolar that there's an ADHD issue. But a lot of times some kids who might look like they have ADHD, it really is a mood disorder, and it's not even ADHD at all. And so that's important to differentiate. In terms of the ASD, the autism comment, it is true that ASD kids can come across as being ADHD because of having sometimes their narrow range of interest, or having areas of high level of perseveration. And so they come across people as not being focused and not paying attention. But it's not an attention focused system. It's a perseveration over focus, but on very specific things. But it will lead to a lot of frustration sometimes in the academic setting or trying to do schoolwork, because they do have a hard time getting started on tasks that are non-preferred, things that are boring, things that just, because of rigidity and flexibility, it can come across as having ADHD. The ADHD medications will not work, nor will the mood stabilizers. That's not something that a medicine is necessarily going to address. That will really need to be addressed behaviorally. It does not mean ASD kids don't have ADHD. It's certainly possible as a comorbidity, as another issue to be there. And I have found that sometimes the response rates for children on the spectrum with ADHD medications is not as good as the non-ASD kids. I hope that was helpful.
Great. Here's a question that's come in. We know we have some of the attendees today are other providers. Here's one. How can therapists have conversations about medications for children, talking to the child about medication, addressing parent concerns, providing realistic expectations for engagement with the psychiatrist, helping the parents choose a psychiatrist?
Yeah, a lot of good questions. We have a few minutes, so I do think therapists have actually a very important role to play, because it's not uncommon that you're the one who's seeing the patients first. As a matter of fact, you're the one who's referring. That's very common for us. We get referrals from outside therapists outside our practice every single day. And because you know the patient so well. I think there's two parts to this. The expectation part, this is really important. And I want to emphasize this. Seeing a psychiatrist, and again, I could at least say about me and our practice, does not mean going on medicine. Because a lot of people, we say this up front to a lot of our patients who call for appointments. Seeing us does not mean going on medications. It means you're doing a diagnostic evaluation to figure out what the issue is and coming up with a game plan. A game plan doesn't necessarily always mean medicine. Sometimes the game plan is for me to go, yeah, I think there's something there. I want to recommend you go back to school with a letter from me recommending a 504 plan with some accommodations. That's it. That there is no indication for medicine. So that's the first point in terms of managing expectations. Getting a psychiatric evaluation, at least in our practice, does not mean going on medicine. The conversation might come up if it's indicated. So it's okay to say that too. But here's the other thing is, I think it's important to communicate that no one is going to force anybody to put their kid on medications. So I think it's important to realize that parents play a huge role in the decision making. They need to be very, very comfortable and have a clear understanding that if the psychiatrist or the provider is not able to explain clearly what it is they're treating and what this treatment course looks like, they should be cautious, because we don't believe we're just going to chase symptoms. Oh, let's just try something. No, I have to have a clear understanding in my own head what it is I'm treating. What is the indication here? So I think it's important to have that kind of conversation, that what you're really looking for from a psychiatrist to do, from a psychiatric provider, whether someone like me or one of our physician assistant or nurse practitioner, is what is the diagnosis? What is the diagnosis? What's going on? You're looking for someone to be able to do that. That you need to ask them, is that part of what you do? Is, will I have a good understanding of the diagnosis and what the treatment plan is? And what does that look like? We have a bias towards a very, very conservative approach. We have a very high threshold for prescribing. If we prescribe, doing it slowly. As a parent of 3 kids, that's what I want for my kids. So, I'm cautious with my own children. So it makes sense for us to be cautious with other people's children.
Here's a question that came in, Dr. Hanna. What meds do you recommend for hyperactivity and ADHD for a young child with autism?
So good question. One of the things I have not mentioned is the non-stimulants. We spent some time on our Ritalin, Adderall, and the stimulants. There's a class of medications. They're called alpha-2A agonists. That's just their mechanism of action. Original blood pressure medications, clonidine and guanfacine. And it's not uncommon that for someone who's really hyper, and assuming they have ADHD, that we tend to start with that, especially for children on younger side, to stay away from the stimulants, because the stimulants can make kids more rigid, more inflexible, kids who are on the spectrum. So we tend to start with those. Again, same rules apply. Low, slow. A lot of times we'll even compound medications into liquid. So I could start below the recommended starting dose. We, by the way, start below the recommended dose. There's all the recommendations you see, I start below them. I think they're still too high. So guanfacine, clonidine, guanfacine comes in 1 milligram, clonidine comes in 0.1. I sometimes think even the half the tablet is still too high. You need to monitor blood pressure on those. They can lower your blood pressure and they can make you tired. So you still need to monitor blood pressure, pulse. They can make you more emotional and more sensitive or more irritable. Everything requires monitoring, monitoring, monitoring. You got to be aware of the side effects. You got to understand when you did a dose, what happened, good or bad.
Very good. Here's one that's come in. A son has turned 10 years old and is currently taking guanfacine, lowest dose, but seems more irritable. Was taking Vyvanse for 1 month, started to get depressed. I've tried for a therapist, but hasn't really lasted, has ADHD and ODD. And I guess a question about, is getting a behavioral coach a good next route? No, it's kind of a specific question, probably hard to answer, but
yeah, I don't know if I could answer that, but one of the things I would tell you, if your child's being labeled with ODD, I don't like to settle for that diagnosis. I always want to kind of just try to do a little bit deeper dive diagnostically to try to understand what's driving those behaviors from a diagnostic perspective, because sometimes there's other diagnoses or other better explanations. Sometimes it's kids on the spectrum come across as ODD. Sometimes it's anxious kids who come across as ODD. Sometimes kids who struggle with their moods come across as ODD. So there's, to me, whenever I hear a story like this, I mean, I can't give you like a specific recommendation without, if you haven't evaluated someone, I can't tell you what to do. But I will say that it always behooves you, when you've done a couple of medication trials, is to reevaluate the diagnostic part. Make sure you're not missing something from a diagnostic perspective. If you run into side effects, and then relook at the is it the way the dosing was done of those medicines, right? You want to really be able to communicate with your provider who's prescribing. Is there somehow, was dosing related to that? Are there other options? In terms of behavioral, I'm not going to say no to someone asking me if there's, behavioral therapy can be helpful, assuming there's a primary behavioral issue.
Very good. Well, thank you everyone for your questions. We got through many of them, maybe not all of them, but a couple things. One, we will share this YouTube with you following up. We hope to have additional Q&A sessions in the future, so you can continue to ask those. And also, if you have specific needs, you want to see if MedPsych would be a good fit, you can visit our website at medpsychealth.com. Thank you so much for joining today and for all the great questions. And we hope to do this again in the near future. Thanks, Dr. Hanna.
Thank you. A lot of
Have
good
a great day,
questions.